lecture is by Dr. De Oliveira. He is the head of Department of Neurosurgery, a Center of Reference CNS Tumor, AC Camargo Cancer Center in Sao Paulo, Brazil. And he would speak about the very important topic of neurosurgical management of paraclinoid aneurysms. Over to you, Dr. De Oliveira.
Hello, everyone. It's a great pleasure to be with you. Here in São Paulo, Brazil is 3:08 p.m. So I know that most of you is all around the world in different time. I'd like to say how delighted I am to be invited to this meeting. I'd like to say thank you for everyone in the Egyptian society, especially to Dr. Sameh Hassan, for this kind of invitation. I'm gonna share my screen with you. Okay, let's see here. I hope you can see my screen. Probably you are seeing a double slide, right?
Yeah, you can play the video.
Only one slide. Okay. Okay, are you seeing?
Not yet.
Oh, great. So my topic today is the neurosurgical management of paraclinoid aneurysms, which is an amazing topic. I have no disclosure on this lecture. If you go to the literature, you're gonna find at least 27 different names to define a paraclinoid aneurysm, or names that define any kind of aneurysm arising since the carotid artery leaves the cavernous sinus up to the origin of posterior communicating artery. So in this segment of carotid artery, any kind of aneurysm arising from that, you can call paraclinoid aneurysms. Every time you face the patient with paraclinoid aneurysm, you have to have a neuroradiological assessment, and every single information for the neurosurgical planning is very important. So the angiography can give us information about the intraluminal arterial features, but also the MRI can bring to us the information about the relationship between the aneurysm and the encephalic structures, especially when you have a large and giant aneurysms, when you have some part of this aneurysm thrombosis. So this is very important information to have the MRI, especially in a large and giant aneurysm. Of course, the angio-CT also can give us information regarding the relationship between those large aneurysms with the other vessels, and also the relationship between the skull base anatomy, especially to the bony anatomy, along with the aneurysm in the vessels. When you face a small aneurysm on this paraclinoid region, sometimes we become in doubt if the aneurysm it is inside the cavernous sinus or it is inside the subarachnoid space. So this is a very important question, and unfortunately, there is not a single exam to give us the right answer for that. So this is an interesting paper that bring the optic strut as the landmark when you have an aneurysm under the optic strut. Probably it is inside the cavernous sinus. When you have aneurysm above it, probably some part of this aneurysm can can cause subarachnoid hemorrhage. So this is an important information in the decision-making process. Of
Excuse me,
course,
sir.
yeah.
Sir, there is a rectangle in the middle of your presentation. Can you please re-share your screen?
Of course.
Thank you.
What's happened? Should I share again?
Yeah, you go
Yes,
back
sir.
on screen sharing. Yeah.
What happened?
You fell off screen sharing.
Okay, so
There was black rectangle in the middle of your screen all the time of presentation.
Okay, should I back to the beginning or should I continue?
As you see, sir.
Should I go to the beginning of the lecture?
Continue, sir. Continue,
Okay.
sir.
You can restart, Mr. Oliveira.
Okay, let me share again.
Now it's okay, sir.
Okay, just a minute. Let me duplicate it. Okay, have you seen the screen?
Maybe your net is weak a little bit. If it's combined with some other instruments, you can just ask them to close the other instruments. Now it's okay, but the square is in the top.
Okay, have you seen the screen?
Yes, it's perfect.
Okay, perfect. So also it is important to analyze the cerebral circulation, the flow, so the balloon occlusion test preoperatively, it's a very important information to know if you can occlude or not occlude the carotid artery. If you cannot occlude, you have to go to the surgery prepared to make a bypass. So it's a very important information in the preoperative. In the preoperative time. And also in the preoperative time, you have to have the neuro-ophthalmological assessment because these aneurysms, they're a very close relationship with the anterior optic pathway. So to have a neuro-ophthalmological assessment in the preoperative time, it's a mandatory step. After that, when you decide to treat this aneurysm with surgery, it's important to know some very basic principles. There are a lot of classification systems for that. I like to use a very simple one. That is those aneurysms arising in the superior aspect of the artery in the closer relation with the ophthalmic artery, and also those ones with a backward projection. Also, we have
I'm sorry. I'm sorry. I got to get that mute. I'm sorry. Okay.
Okay. So there are some aneurysms arising from the middle wall of the carotid artery. For those in the hypophyseal segment of carotid artery, and also those arising inside the cave. I'm going to talk about that in the future. So for those aneurysms in the upward projecting, we're going to use a direct or curved clips. This is a very basics, but for those projecting downwards, I have to have some fenestrated clips. So it's a very simple classification. Another basic step is to know the anatomy, especially the bony anatomy in the skull base and the anterior clinoid process, points of attachment in the sphenoid wing and the optic struct in the optic canal. So these are the three points where the anterior clinoid process is attached. So when you have to remove it, it's important to drill those bones in order to remove it. When we remove the anterior clinoid process, we expose this small segment of carotid artery, which is the clinoid segment, and you can see here the ring, the distal ring, the origin of ophthalmic artery, the optic nerve, the carotid artery, the cavernous sinus anatomy. So this is very important anatomy. And the only way to understand this anatomy is going to the lab and practicing to open the specimens, cavernous sinus, so to understanding this anatomy is the only way to give a confidence to operate those kinds of aneurysms. So going to the microsurgical principles, we have some very important steps: the positioning, the Sylvian fissure opening, the anterior clinoid process, and the clipping. Clipping is not single to put a clipping and leave the surgery. Clipping is a process. We're going to talk about that. So about the position, when you have a paraclinoid aneurysm, it's not necessary to extend the head. You have to put the head, especially in my practice, we put the head parallel to the floor, because if you extend the head, you're going to put the skull base far away from you. So I like to put in this position. Another basic principle, which is to have a proximal control. And for paraclinoid aneurysm, the proximal control is in the neck. So for me, and in my practice, we start the surgery in the neck. So we start to dissect the carotid artery in the neck, and then you go to the craniotomy. Remember that we have connections between external carotid artery with internal carotid artery. So if you have to control some intraoperative bleeding, I like to put a clip on the common carotid artery, because if you occlude only the internal carotid artery, you can have some flow coming from the external carotid artery through the ophthalmic artery. So if I need some proximal control, I like to put a clip on the common carotid artery. Choosing the best craniotomy approach for paraclinoid aneurysm, I believe that PTERIONAL approach is enough for 99% of the case. I like to do the regular craniotomy. I couldn't agree more with Professor Juha Hernesniemi comments about small craniotomies. So I like to perform regular or large craniotomies. Of course, when you have a large and giant aneurysm, some exceptional cases, we can perform an ORBITOZYGOMATIC approach, which give us some different angles of approach. So sometimes I like to use that. I'm going to share with you some cases that illustrates the way we deal with those kinds of aneurysms. This is a female, 16 years old, presenting with bilateral paraclinoid aneurysms with left visual depth. So you see here the campimetry preoperatively. In the MRI, you see this left large upward projecting aneurysm right here, and you can see another one, the right side. When you see the angiograph also is consistent with a large paraclinoid aneurysm in the left side projecting upward, and in the right side you have another one projecting downward. So because the patient had a visual depth on the left side, we decided to go firstly to the left side. I hope you can see the video. Are you seeing the video?
Yes, we're seeing it a little slow. It's okay now.
Okay. So you can see here the carotid artery, the aneurysm, the optic nerve, the origin of ophthalmic artery right here. I'm putting a pilot clip just to have the control of the situation. Of course, I'm seeing here the residual aneurysm right here in the up part of the carotid artery. You see that this aneurysm is causing some kind of mass effect of the optic nerve. You see the area where the optic nerve was compressed. So just cutting the arachnoid, we can separate the aneurysm from the optic nerve. I'm going to put additional parallel clip. I can see here also the pituitary stalk right here, but I can see also a residual aneurysm right here. And then puncturing, aspirating, suction the aneurysm, you gain space. So I'm using now a fenestrated clip in order to occlude that residual aneurysm in the inferior part of carotid artery, keeping the previous two clips inside the fenestration. Coagulation of the aneurysm sac, it's useful in some situations. You can see right here residual aneurysm, and also we coagulate a little bit more the aneurysm wall in order to reduce those aneurysms, residual. And then we put additional clip in order to achieve a complete occlusion. The clip was not in a good position. I'm gonna reposition it, and now yes, to get that still a small piece right here, and we put another additional clip in order to occlude completely. I hope the video is running well. And this is the post-operative angiography. This is another mandatory step for me, is to perform a post-operative angiography in order to have a comparison between pre and post-operative, to make sure that there is no residual aneurysm, and also to have a preservation of carotid artery and ophthalmic artery and in every single artery involved in the aneurysm complex. So some months later, we went to the right side. Look at that. It's a completely different, the same patient, but it's a completely different situation. Aneurysm projecting downward. I don't have I cannot see the whole aneurysm complex. We thought to remove the clinoid process, to open the cavernous sinus, to open the dural, distal dural ring. I like to clean the clinoid. This is the third nerve right here, free edge of tentorius. This is the anterior clinoid process. I like to clean up every single piece of the dura over the clinoid, because it makes my drilling process easier. This is the origin of ophthalmic artery. So I start to drill the bone. You can have some kind of bleeding from the bone. If the bleeding is from the bone, you can stop easily using bone wax. And when the bleeding is from the cavernous sinus, you have to use some kind of fibrin glue. So you can see here, now that we drill the points where the clinoid process was attached, we can detach the clinoid from the dura. Be careful, because mostly of the clinoids are very thin point like this one. You can perforate the carotid artery with this point. And then we start to cut the distal dural ring. Is the only way to detach this ring is cutting. We cannot dissect it. So sometimes we still have a very small piece of bone, which is the optic strut right here. So it's important to remove it in order to have access to the middle wall of carotid artery. This is the lateral wall of sphenoid sinus. And here is the origin of the ophthalmic artery. Now I'm still cutting the distal dural ring in the middle wall of carotid. Look at how easy it is to mobilize the carotid artery as soon as you have the whole circumferential ring cutted. Now you can have proximal control right here in the clinoid segment. You can mobilize the carotid artery. You have the whole control over the ophthalmic artery. And now I'm doing a trapping in order to start my clipping process. You can see here the origin of anterior choroidal artery and the posterior communicating artery. Because it was a large neck aneurysm, I had to put another clip. I'm using a Doppler to analyze the flow in the posterior communicating artery right here, and now in the anterior choroidal artery. So, and this is M1 and A1. So I'm checking the flow in all vessels involved in the aneurysm complex, checking if the whole aneurysm neck is included by the clip, and now to aspiration of the aneurysm in order to alleviate the mass effect of this. And look at how the pituitary stalk also was compressed by this aneurysm. So this, when you have aneurysm with mass effect, we have to achieve complete occlusion, but also to achieve the mass effect relief. Again, postoperative angiograph showing a complete occlusion and preservation of all arteries, including the ophthalmic artery. In this case, because we could relieve the mass effect very early, the patient could achieve a good recovery of the visual deficit, but time is a very important factor on this recovery. We have published about that with aneurysm present with mass effect with some points of the anterior optic pathways. In this paper, we observed that the visual deficit is related to not one single aspect like direct compression, like we have seen this example right here. Look at how ischemic was the optic nerve here. But also we can have some kind of pulsation over the optic nerve, as we see on this example right here. And you see in some situations like that where the optic nerve is entrapped into the optic canal. So in these situations like that, we have to open the optic canal in order to relieve the mass effect. And also when we have some calcification and thrombus inside the aneurysm, you have to open the aneurysm to remove it in order to achieve the best clip applying on this case, because sometimes the clip cannot put in a good position because of the calcification or even some sclerotic thrombus on the wall of the aneurysm. So the pathophysiology of visual deficit is a multifactorial, it's not single factor relation. So we have to identify every single different aspect of this pathophysiology and to choose the best technique to relieve all of those. When you go to the literature and see the this kind of aneurysm treated by endovascular techniques, we're gonna see that the rate of complete occlusion, it's low, around 80%, but can be very, very low, around 21%, with high rates of recurrence, 53%, retreatment, 70%, and up to 40% of complications. And it's easy to imagine that it occurs because when you put coils inside the aneurysm sac, you can enlarge the degree of distension up to 34% when compared to a region of the size of the aneurysm. So it's an easy way to explain why those patients have some visual loss after coiling. There are a lot of publication about that. You can have also compression of coil mass of the optic nerve, but the pathophysiology is not only compression. You can have some kind of inflammatory mechanism around the aneurysm sac, as you can see in this publication, in another publication talking about that, especially when you use bioactive coils. So be careful when you recommend coiling for those aneurysms with mass effect, because you have, in some situations like this one, to go after coiling to a surgery in order to decompress the mass effect. Talking a little bit about those aneurysms arising from the middle wall of the carotid artery. This is an example of that. You see a multiple aneurysm, MCA, anterior choroidal artery right here, a superior lateral wall of the carotid artery, and also this aneurysm arising from the inferior wall of the carotid artery. So this is the MCA. So it's a very important step is to widening open of sylvian fissure. This is a natural way, the natural corridor to have access to the vessel. So this is the MCA. So here you can see the anterior choroidal artery arising from very close to the origin of the aneurysm right here. So I have to put a clip in an oblique position in order to preserve the origin of the anterior choroidal artery right here. This is a posterior communicating here. So the ICG confirmed the preservation of the anterior choroidal artery. This is the superior lateral. So I'm not seeing the aneurysm in the medial wall, and the carotid artery, it's attached by the distal dural ring. So the only way to expose this aneurysm is again opening the cavernous sinus. I'm removing the dura of the anterior clinoid process, the drilling of the bone, and then removing the clinoid, exposing the clinoid segment of carotid artery, start to cut the distal dural ring, and after that you can stop the bleeding with fibrin glue, and now you have some visual part of this aneurysm. In this situation, I didn't have a fenestrated 90 degrees clip, so I decided to apply the multiple clips fenestrating tendon in order to achieve a complete occlusion. I can see the residual aneurysm right here, and I put additional clip. So now I can see the whole aneurysm sac, including in the clip, and then a new ICG injection confirmed complete occlusion and then the preservation of the all vessels. And this is a post-operative angio-CT. When you have an angiography showing aneurysm projecting downward in an oblique project, not a parallel like the previous one, but in the oblique project, we have to think that this aneurysm can be inside a cave. This was described by Professor Kobayashi in 1989 when he described the cave and some aneurysms arising inside this cave, which is a recess in the medial wall of the carotid artery. This is Professor Kobayashi. It was in the Istanbul in the old Congress. I have the great pleasure to be with him. This is the cave. Okay, this is a small recess in the medial wall of the carotid artery. In this original description, Professor Kobayashi showed us that the cave can be small, like this one. The cave can be a little bit larger, like this one, but in 30% of the cases, there is no cave. So in this situation, all aneurysms arising from this medial wall should be classified as a hypophysio and not a cave. This is a nice illustration from BNI group showing what is the cave, and because of this recess, we can have a small aneurysms in this cave. We can have a large aneurysm, but we have also a transitional aneurysm. Some aneurysms arising inside the cavernous sinus, and part of the aneurysm going into the subarachnoid space. This is a very interesting example, and we have to be careful in this kind of aneurysm, because sometimes we consider that aneurysm is completely inside of cavernous sinus, but this aneurysm can cause subarachnoid hemorrhage in the patient. This is an example of this, one of illustrative case of carotid cave. It's the same technique. We have to start with proximal control, the position parallel to the floor, proximal control in the neck. We have control of the carotid artery. Again, look at, you can see the carotid, the origin of ophthalmic right here, the optic nerve. You have the anterior clinoid process right here, left side. We start opening the falciform ligament, but you cannot see nothing. The only way to clip this kind of aneurysm is to open all this bone. You have to remove the bone in order to have exposition and space to put a clip. So again, we go directly to the attachments of clinoid process. Try to remove the clinoid as a single piece. Sometimes we decide to drill everything, but mostly of the time we try to remove as a single piece. Like you see right here, when you remove the clinoid, you have exposition of the clinoid segment. Look at, there is some bleeding coming from the cavernous sinus right here. So Professor Hess's name has published along with Professor Ali Christ about that. It's a very elegant way to stop the bleeding. So after you remove all the bone, you have the exposure of the clinoid segment. We have the carotid artery distal to the aneurysm. We have the origin of ophthalmic artery, and you can see the aneurysm inside that small cave. Remember that there is a bone. The cave has a bony edge in the whole cave. So It's not easy to put a clip, even when you have the whole exposition like this. So in this case, I've tried a lot of times to put a clip, a fenestrated clip right here, but because we have a bony edge in the cave, I couldn't put it. So I decided to put two fenestrated clips in tandem with the tips of the clips inside the cave, and then the residual aneurysm was occluded using a curved clip, as you can see here. The ICG, it's a beautiful device, a beautiful tool to give us the certainty that you have a flow after clipping. So as you can see here, we put two clips fenestrated. The tip of the clips is inside the cave, and the residual aneurysm right here was occluded using a curved clip, preserving the carotid artery and also preserving the ophthalmic artery. So now you can understand better the clip position. So the cave is a cavity which was right here. So because they have a bony edge, sometimes it's very tough to try to put a fenestrated clip in a right position in order to achieve a complete occlusion. So sometimes we have bilateral aneurysms, like in this case, you can see here right MCA and a small aneurysm arising from the infundibular posterior communicating artery right here. In the contralateral, in the left side, we have aneurysm in the paraclinoid region. This is the ophthalmic artery in the medial wall. When you have a small aneurysm like this, here is the right side. The small aneurysm was clipped. Now you can see here, right optic nerve, left optic nerve. And for a small aneurysm like this, we can have some space to have a proximal control here, and you also can try to put a clip here. So you see that the space is very, very narrow, but it's possible to put a clip and achieve a complete occlusion. In exceptional cases like this, now you can see the position of the clip here. So for some very specific cases, the contralateral approach for paraclinoid aneurysm is feasible. Of course, this segment of carotid arteries has been used for the endovascular treatment using a flow diverter. You have to keep in mind that using flow diverter, as you can see in this publication, can change the flow in the ophthalmic artery in at least 32% of the cases. This is a very interesting paper published. It's a randomized care trial and registry about flow diverter. And remember that flow diverter is mostly indicated for unruptured aneurysms. So when you see the results with these devices, you can see the 10% rate of death in this paper with 48% of complications, and the rate of total occlusion reached only 50–80%. So based on these numbers, I have to say that this is not a good indication. It cannot be the first option for aneurysms in this segment. And also in this paper, some patients have to be crossed over for surgery in order to relieve the mass effect caused by the aneurysm along with the endovascular treatment. Also, there are two meta-analyses about these flow diverters, and you see the total occlusion reaching 76% in both of ones, with morbidity among the from 5 to 10% morbidity, and mortality around 4%. Again, when you analyze the tool that you use for unruptured aneurysm, and then you have a rate of mortality around 4%, we have to think about that because it's not a good result. And also 76% of total occlusion, it's a low rate, especially when we compare with those series where the microsurgical followed by a postoperative angiography showed to us that the worst result was 81% in 1963. Because we've considered the modern and more recent results, we can achieve more than 90%, or in some series, very close to 100% total occlusion. So we have to compare that because the microsurgical technique is still providing a better result regarding total occlusion, and I have no doubt about that. So in conclusion, when we face a patient with a paraclinoid aneurysm, we have to achieve a very good assessment with images. Those aneurysms have a very close relation with anterior optic pathway, so a neuro-ophthalmological assessment is very important. We have to remember that the pathophysiology is multifactorial. We have at least 4 different mechanisms to that, so we have to recognize which mechanism the patients have in order to relieve this mass effect. And based on that, the microsurgical management should be considered first, and also we have to have the knowledge about the microsurgical anatomy. We have to improve our microsurgical techniques, where we have to decompress the cranial nerve as soon as possible, and we strongly recommend some kind of intraoperative blood evaluation, ICG, microdoppler, any kind of intraoperative blood evaluation. And endovascular management should be recommended for some alternative in selected cases, because this technique has some lower rates of complete occlusion, high rates of recanalization. It is not recommended for large and giant aneurysm, and in our practice, it's a contraindication for patients with visual deficit, which makes the microsurgical management as the first choice in the treatment of paraclinoid aneurysms. I'd like to invite everyone next week to be with us in this webinar with Professor Juha Hasniemi and also Professor Bin Shu. It's going to be in Brazil, September 9th, 8 p.m., but in China, it's going to be September 10th, 7 a.m. So most of you and every one of you are most welcome to be with us on this webinar. This is a Santa Casa de São Paulo, and you are most welcome to visit us anytime. And this is a C. Camargo also. You are welcome to come by with us. Thank you very much for your attention.
Thank you, Dr. D. Oliveira, for this fantastic lecture. It was great, and especially seeing the results of flow diverters and endovascular methods and your results. It's fairly clear that surgery has a very, very big role to play. We will take some questions. Professor Chaudhary asks whether you open cavernous sinus to make the surgery easier. Is that one of your strategies to do that?
Oh, he may not have heard that question.
Okay. Yeah. Whether do you open the cavernous sinus often to make the surgery easier, or is that not required? Dr. Oliveira, can you hear me?
Yeah.
Yeah.
Yeah. Okay. No, as you could see, in my first illustrative case, I've shown a large aneurysm, the bilateral large aneurysm. In the left side, I open the dura. I see if I need to open the cavernous sinus or not. In that case, it was a good example in which I didn't have to open that. I could put a clip in. I could see the neck of the aneurysm, the whole neck, and in that case, it was not need to put it. So the only way to know if you need to remove the clinoid to open the cavernous sinus is to open the dura, to see the aneurysm, to see the relationship between the aneurysm and the bone structures, the relationship between the aneurysm and the optic nerve, and then you decide if you need. And also, you can tailor how much you need to open the cavernous sinus, the bone removal, and also the ring cut. So it's not necessary for every single case.
Yeah. I would ask a question. Which of the cases would you prefer to have a flow diverter placement for the aneurysms as against microsurgical removal? And the second question is, which of the cases you would do prepare for a bypass for these patients?
Yeah. In my practice, the flow diverter is the first choice when you have an aneurysm completely inside the cavernous sinus. When you have an aneurysm that cannot offer any risk of subarachnoid hemorrhage. If the aneurysm can cause some kind of subarachnoid hemorrhage, I have to consider that microsurgical clipping is the best choice for a total occlusion of the aneurysm. So I have to try it as a first option. So the only situation that I consider endovascular treatment as the first option is when you have the aneurysm completely inside of the cavernous sinus, and if this aneurysm is causing any kind of symptoms. Because if the aneurysm is asymptomatic, I do not recommend any kind of treatment. Okay. Of course, we have some patients that have other clinical conditions that cannot be a good option for surgery. Patients with cardiac and cardiac problems that contraindicate a surgery like that. So on this situation, the endovascular procedure is also can be a first choice. So I do a preoperative angiography for every single case. And when I have a paraclinoid aneurysm, I ask for balloon test occlusion for every single case. When you have this information, you have a condition to decide if you have to be prepared for a bypass or not. And I always try to occlude the aneurysm using a clip reconstruction. If it is not possible, I have to change my strategy in the surgery for a bypass. That's the way we consider during the surgery.
Somebody asks, how many hours each week do you think a resident should practice in microsurgical lab to learn to operate these kind of aneurysms?
How many what?
How many hours each week?
You mean in time? How many years?
Yeah, in time, yes.
Okay. I don't know. I don't know how to answer this question. Because I think you have to go every time you can, every time it's possible, because to train the microsurgical technique, to understanding the anatomy is completely different when you are reading a book, when you are seeing somebody else in the operating room, and then when you are personally doing the dissecting. It's three different situations. In every situation you learn, but the only way to have confidence to open the cavernous sinus is to do by yourself, first in the lab. So I cannot measure in how many years or how many times you have to go and open specimens and then go to the surgery. I have to say that you have to practice how much you can. And then when you have confidence, when you have sure that you understanding the anatomy, because the first thing in the cavernous side is to understanding the anatomy. Because when now I have to say that my first cases in the paraclinoid, I didn't understand the anatomy the way I understand right now. So you have to practice as much as you can in the lab.
Thank you.
My teacher in anatomy in 1960s in Zurich, Professor Gian Töndery, he was shouting in the lecture, medical study is a lifelong study and anatomy even more. So this is a good sentence, and I think we have to learn all the time. And I never had a good possibility to practice in cadaver laboratory because of cultural and other reasons, but I learned to do. I liked Dr. Oliveira's lecture very much, and it was sound and good surgery. And what I want to say there, I'm using as proximal control, I'm using the intracavernous carotid artery. So I put the clip after clinoidectomy there, and then this is a good place to put the temporary clip because seldom has atherosclerosis, which is very common in China. So it is terrible atherosclerosis here. So this is very good place. For some reasons, it is not attacked by the atherosclerosis, this part of carotid artery. So it is good place to put temporary clip. So this is my way, but otherwise I totally agree what Dr. Gian Oliveira said. So it was nicely, thank you.
Thank you, Professor Ernest Niemi. Coming from you makes me very honored. And as I said, I start the surgery in the neck, but as soon as you open the cavernous sinus, you have the clinoid segment of carotid artery and also part of the cavernous sinus carotid. So you have a space to put a temporal clip. So you don't need any longer the neck for proximal control. So it's, but it's still, I'm still doing the neck proximal control.
So just to continue, so I tried to have balloon control, but I had 3 dissections in internal carotid artery with balloon. So I stopped that. So this was my bad experience. So I didn't like, so it is better to have direct surgery with whatever you put on around the carotid artery or then intracavernous carotid artery. It was very sad to find out that there was no blood coming from carotid artery when you opened the aneurysm. Right. And the patient poor outcome.
Right. Thank you very much. I would hand it over to Dr. Sameh. Yeah.
Nice presentation, John, as usual. How are you?
Great, Amir. It's very nice to see you.
And I just also wanted to, well, congratulations for your talk, as usual, and just comment to what Professor Ernest Niemi just mentioned. I think the last time I opened the neck for paraclinoid aneurysm was about 3-4 years ago, and we routinely now use balloon for this aneurysm. And I understand, I agree that there is a risk for dissection, there is a risk of heparinization, but maybe we have been lucky. We do this in the hybrid suite, so maybe the quality of visualization of the endovascular manipulation is better. But once the balloon is there, then when we inflate the balloon, there is no control. It's just by the measurement of the amount of cc of fluid that we need. We can also do suction decompression. And I can tell you over the past 4 years, we never had any hemorrhagic or stroke complication. One patient had woke up with a hemiparesis while intraop angiography was good, and we got an MRI. There was no stroke, but the patient has hemiparesis and improved. So I guess that was probably related to something that we did not found. But in our experience, using balloon has been safe, and specifically if you do this surgery for younger patients who they do not want to avoid an incision in the neck, I think that's definitely an alternative. But I appreciate Professor Aneurysm's comment. That's a risk, so it depends on institutional also experience with that.
I have used that a couple of times. I think I have to say that it's very useful for suction decompression, and also you can perform an intraoperative angiography, which is very, very nice to have control, because ICG has some limitations on this region because of the bone. Yeah.
You miss the degree of narrowing of carotid if you don't do intraop angiography.
Yeah.
You think it's good, and then you have a post-op angio shows 70% stenosis. So I think this specifically large aneurysm in 2020, if we do operate on them instead of endovascular treatment, you need to get the best result. If you don't get the best result with this aneurysm, endovascular is they're gonna kill you. They're gonna say, well, we can do much better with the flow diverter, stuff like that, remodel the lumen. And in order for us to be competitive and show that the surgical results are good, we absolutely need to have the best confirmation. And as you said, the best way is intraoperative angiogram.
I think that you have to change the position. You have to kill the endovascular, because they have a very, very bad results when compared with you. So when you have some kind of bad result for a single case, they come to you and try to kill you. But they have results every single day that we could kill them. So
that's right. But
we have to change the position.
You know that the trend is toward endovascular. So it's a treatment that is perceived less invasive. And you and I and all the experienced people in the panel, they know that if you dig into the data, even in our own institution, we might have a mortality from endovascular treatment of ophthalmic aneurysm, but we never ever had a mortality from treatment of surgical treatment of ophthalmic aneurysm, period. Never a serious complication, never. My rate of stroke or mortality is close to 0, but it's an invasive treatment, so that's the problem.
Both are invasive. The results tell us which is invasive or not.
I understand. This is,
yeah.
I 100% agree with that, but you know what I'm talking about. This is the trend going toward endovascular.
Yeah.
A lot of psychological and financial investment.
Of course.
And the result, you know, the remodeling, when it works, we have to agree, the remodeling of the carotid artery with a pipeline device or any flow diverter, when it works, is beautiful. But it's not 100%.
Yeah.
If it's 95 to 100%, then yes, but we are not there yet.
Yeah.
Anyhow, thank you very much for your talk. And
thank you for your comments. Thank you very much.
Okay, thank you all. Okay, thank you. We now open a discussion for the panelists to be again discussion about all 4 talks and lectures. Please, the panelists, unmute yourself and ask your question directly. Thank you. Okay, I will share my screen now to Professor Lawton to answer questions from his lecture. Okay, sir, are you here? Professor Lawton.
Yes. Can you hear me?
Yes. Yes, sir.
So
Now questions are
so
shared.
do you want me just to answer these?
As you see, sir.
Yeah. Okay. Well, so the first question is, how often do I use neuronavigation to reach my target? And the answer is that all the time. I use navigation 100% of the time because I think you really need to have some sort of an imaging guidance system that takes you to your target. Now, that said, I think it's very important, and I hope this came off in my speech, was that you need to rely on the anatomy because navigation fails, navigation sometimes glitches, there can be inaccuracies, so it's important to also correlate your target with surgical anatomy. So the answer is use navigation, but also train yourself to use anatomy as your own pure navigation. Now, the next question I see here is, thank you very much for the lecture. How long does the patient stay on the ventilator? In our experience, the duration is much long. Thanks. We try and extubate our patients immediately. We generally don't have any trouble doing that. If there's some concern about respiratory drive, and typically that comes with surgery in the medulla, then there may be some slowness to extubate, but there may also be some patients that are left on the ventilator if the case finishes very late in the evening. But by and large, the vast majority are extubated immediately.
Thank you, dear Professor, for honor today. Is there any comments from you or any questions to any lecturers? Professor Lawton, are you here, sir?
Yes.
Is there any comments or add-on for your lecture?
Oh, you mean additional comments from me?
Yes, sir, if you want.
No, I don't have anything additionally to say. I'm happy to take questions if there are questions.
Okay, sir, I think this is end. And thank you for honor today. Thank you, sir.
Thank you.
At the end of session, I'd like to thank our dear professors, speakers, and moderators, Professor Yuha, Professor Lawton, Professor Boyle, Professor Dahdashti, Professor Chandra, Professor De Oliveira, Professor Manas, and Professor Dandy. I'd like also to thank organizers, Professor Borba, Dr. Bezwas, Dr. Joanna, Dr. Helmi, Dr. Abiram, and Dr. Jupiter. I'd like to remind you all that our session will start tomorrow, half an hour before time we started today. And I'd like also to invite you all to our endoscopic spine congress that will be at 19 and 20 September 2020, and we will send link of this Congress on all our 33 groups. Thank you. Now, if any moderator or speaker want to say something, floor is him. Thank you.
Okay, Sam, thanks for putting all this together. This was quite a lot of work. You did a great job, and we'll see you all tomorrow. Thank you.
Thank you.
Thank you.
Good night.
Thank you.
Thanks.
Thank you
Good
very
night.
much.
Thank you. Thanks. Good night.
Thank you.
Thank you.
Okay.
Okay, thank you all, and we meet you half an hour before this time tomorrow. Thank you all. Thank you, dear professors and mentors. Thank you.
Thank you very much.
Yeah, we got through, Sam.
Okay. We have
Dr.
finished.
De Oliveira, I was keeping my fingers crossed with your internet. The Wi-Fi
okay,
wasn't too good.
But it was informative.
The
I will
videos,
ask him.
the video's running?
No,
Was running?
no, it was okay. A couple times
Okay.
it was a little.
Okay.
It was so not so clear. Not so clear.
No, we heard most of it. No, there was no problem.
Okay.
Most of it. It was just a couple
But
of places.
it was very highly informative, sir.
Thank you. Thank you
Thank
very
you,
much.
sir. Thank you.
Thank
Meet
you, John.
tomorrow.
Thank you, sir.
Okay, Mike, I talked to the gentleman from Barrows.
Oh, good.
Okay.
I sent him an email, so we'll video chat and move forward.
Perfect. Yeah. Why don't you guys talk, and then I'll check in with Derek, and then we'll figure out what we need to do from there. Okay.
Yeah, super. Great.
All right.
Thank you, Michael.
Yeah. Thank you. Nice work as always.
Great. Yuha, it's late, man. It's 3 o'clock in China. 3 o'clock in China.
3:30.
3:30 in China. And you're asking me how do I stay up?
Yeah. It's a very, very good lecture. Thank you very much. I learned a lot.
That's great.
Thank you. Thank you.
That's great.
Thank you.
Okay.
See you tomorrow.
Okay. We'll see you tomorrow, everybody. Thank you, Sam.
Okay.
Great job,
Thank
Graham.
you.
Great job.
Goodbye.
Thank you.
Goodbye.